Today, the topic of discussion is going to be the orbit. Now, for non-interventionists or for neurologists and neurosurgeons, we might not really understand what the orbit is. But when we are transiting from a simple metameric system, for example, the mucocutaneous arteries of the face, they are all metameric arteries. So when we are transiting from this simple arrangement in which you have a single artery which will supply everything of that metamere, that means the central nervous system, the peripheral nervous system, the muscle, the fat, the tissues, the aponeurosis, everything will be supplied in that metamere by one artery. The moment we come to the orbit, we start realizing that the orbit is a place which contains metameric structures, of course, the extraocular muscles, as well as the fat, the aponeurosis, the supportive tissue. That means basically the mesodermal derivatives, the prebranchial somite derivatives. But at the same time, it also contains the peripheral nervous system. The peripheral nervous system in the eye, apart from the cranial nerves which are there in the eye, is basically the retina. The first order neurons of the visual pathway are in the retina. So you have metameric tissues, you have peripheral nervous system, and then you have the optic nerve. The optic nerve basically contains the axons of the second order of neurons. Therefore, that belongs to the central nervous system. So when we are looking at the orbit has three contents. Content number one is PNS, peripheral nervous system. Content number two is CNS, central nervous system. And content number three is basically mesodermal. That is the derivatives of the prebranchial somite. So when we start discussing about the vascularization of the orbit, we will automatically start realizing that there have to be at least three distinct different sources of supply which converge in the orbit. You have to have mesodermal supply. Mesodermal supply will come from a metameric artery. The metameric artery has to come from aorta or its equivalent in that area. As far as the central nervous system supply is concerned, the central nervous system supply has to come from the artery which is in the vicinity of the orbit and is supplying the brain. So you will have to have a vessel from the circle of Willis or from the supravilician system which will supply the central nervous system part of the orbit. And then you will have the peripheral nervous system, which again, like we discussed in the spinal cord, will carry the supply from the aorta or its equivalent via itself to the nerve in the orbit. So these three things are required to be explained whenever we start talking about the blood supply and the embryogenesis of the orbit. Now, what I will do is skull, anterior cranial fossa, middle cranial fossa, posterior cranial fossa, foramen magnum. So we will be concentrating in this area because after all, the orbit is very closely linked to the anterior cranial fossa, or we can say that the anterior cranial fossa is basically an extension of the orbit. The orbit is peculiar in the way that it is extracranial, but it contains brain tissue. So all these points put together, we will concentrate on the anterior cranial fossa for much of today in today's discussion. And we will try to make sure that all those three structures which are contained in the orbit are getting their own blood supply from somewhere. We will also try to make sure, and we will try to explain how the dural tissue of the anterior cranial fossa, that is the roof of the orbit or the floor of the anterior cranial fossa, gets its supply from the orbital vessels itself. So Now, what I will do is, this is the midline. That is the cribriform plate of the ethmoid. Somewhere there you have the crista galli. These are the perforations in the cribriform plate. That is the sella turcica. That is the anterior clinoid process. This is the anterior clinoid process going in that direction, so that this area now is the middle cranial fossa. This is the anterior cranial fossa. So what we can do is, we can just make a dissection. We can cut a hole in the roof of the orbit. Now we are looking at the whole thing from above. We have removed the orbital plate of the frontal bone, and we are looking at the intraorbital contents from above. What we see is, you will have the optic nerve forming the optic chiasma. This optic nerve will enter the orbit through the optic foramen. The optic nerve will come into the orbit, and somewhere here you will have the globe. Now, the classical discussion is, the classical explanation that has been given is that the internal carotid artery, that is the carotid siphon, the internal carotid artery, as it becomes intradural, as it penetrates the distal dural ring, right below the optic nerve, below, inferior, it gives off the ophthalmic artery. This ophthalmic artery travels along with the optic nerve in the optic foramen, stays under the optic nerve, and then goes a bit laterally. And once it enters the orbit proper, it stays on the lateral side of the optic nerve till the point that it reaches the globe. Just at the globe or before the globe, it makes a big turn where it comes superior to the optic nerve and comes from lateral to medial. And once it reaches the medial aspect of the globe, from here it continues along the medial part of the orbit to ultimately emerge at the edge of the orbit and contribute to the supraorbital and the supratrochlear arteries, and also give a medial branch which descends downwards and goes to the nasal cavity, where it anastomoses with a branch of the facial artery. Now, as this optic nerve is traveling in this direction, I'll make it thicker so that it becomes more visible. As this optic nerve is traveling in this very complex and convoluted course, it gives some branches. The first branch that it gives, while it is still under the optic nerve, or while it is still lateral to the optic nerve, is going to be the central retinal artery. The central retinal artery will emerge from the ophthalmic artery under the optic nerve, and it will penetrate the optic nerve and ultimately reach the retina. Anywhere in this segment, that is, the segment which is either below the optic nerve or lateral to the optic nerve, till the point it curves around and goes from lateral to medial, you will have the origin of two more vessels, and these vessels are basically the long ciliary arteries. Now the long ciliary arteries, 2 in number, sometimes they can be 3, will ultimately reach the equatorial area of the globe. Now if that is the globe, that is the anterior chamber, that is the posterior chamber, these arteries will reach around the equator of the globe, and ultimately these are the arteries which will ramify on the surface and supply the choroid. What we see as an angiographic equivalent of the visual system, the so-called blush, what we call as the retinal blush on the angiogram, on the lateral angiogram, is not retinal blush, it is basically choroidal blush. So what you are calling as retinal blush is actually the blush of the choroid. The central retinal artery is so small that it does not produce a blush which is visible in routine angiograms. So till now, we have established that we are going to have the blood supply to the entire visual system from this particular artery. Till now, we have not been able to supply, for example, till now what we have done is we have supplied the peripheral nervous system, we have supplied the central nervous system, but we have no idea so as to how to supply the mesodermal system. So for the mesodermal system, just at the point where the artery goes from lateral to medial, you will have one more branch that will ultimately go and supply the lacrimal gland. So this is the lacrimal branch of the ophthalmic artery. As this branch, which is going medially along the roof of the orbit, the moment it reaches the cribriform plate, it will give 2 branches, which will go through the cribriform plate. These will be the posterior ethmoidal arteries and the anterior ethmoidal arteries. The posterior and the anterior ethmoidal arteries will supply the entire dura of the anterior cranial fossa. You'll have on both sides. One more important branch, which sometimes originates from the anterior ethmoidal artery, is an artery which goes upwards and completely along the midline. That is the artery of the falx cerebri. While these structures are supplying the entire neural tissue and the supportive tissue in the orbit, there will also be a branch which comes from this segment of the ophthalmic artery, but this does not, this is a recurrent branch. This comes out, this comes back, it comes outside the orbital space at the cone, but this will not travel along with the ophthalmic artery. The ophthalmic artery has entered via the optic canal. This branch is going to come out via the superior orbital fissure. And ultimately, it's going to go back and anastomose with a branch of the ICA in the cavernous sinus, that is the ILT. So whenever you're talking about the orbit, the orbital vascularization, this is what you have to understand. What you have to understand is that in the most common disposition, the ophthalmic artery arises from the supraclinoid ICA, enters into the orbit along with the optic nerve via the optic foramen, goes below the optic nerve and then laterally, where it continues up to the globe. Before reaching the globe, it gives the supply to the peripheral nervous system, that is the retina, the central retinal artery. It also gives supply to the central nervous system, that is via the ciliary arteries. It gives off a lateral branch which goes to the lacrimal artery. It gives off a medial branch where it continues along the medial wall of the orbit, medial and superior wall of the orbit, to ultimately emerge outside to form the supraorbital and the supratrochlear arteries. It gives a medial branch over there, which goes in anastomosis down with the nasal branch of the facial artery. It also gives you the posterior ethmoidal system, the anterior ethmoidal system, and the artery of the falx cerebri. It may give a recurrent branch which comes out again from the orbit via the superior orbital fissure this time, and this branch anastomoses with the branch of the ILT from the cavernous segment of the ICA. You can have one more branch at this level. The superior orbital fissure, actually, this is an exaggeration. The superior orbital fissure is actually like this. It's quite a long structure. So at the lateralmost part of the superior orbital fissure, you can have a branch which again leaves the lacrimal artery and goes out through the lateralmost part of the superior orbital fissure, and this anastomoses with a branch of the middle meningeal artery in the middle cranial fossa. So these are the number of vessels that you have to see in the orbit. Now, this is what you see in a given angiogram, but this is not the complete story. For example, this will not be able to explain how sometimes the ophthalmic artery can arise from the cavernous segment of the ICA. This cannot explain the possibility that how sometimes the ophthalmic artery can arise. कोई आवाज कर रहा है पीछे. This cannot explain the possibility how sometimes the ophthalmic artery can arise from the middle meningeal artery. This cannot explain the possibility in certain situations where the entire anterior cerebral artery can originate from the middle meningeal artery. This cannot explain the situation in which the anterior cerebral artery gives rise to the ophthalmic artery. So this is the final disposition that you see. But what is important for us to understand is how we reached here. So if we try to understand how we reached at this final disposition, we have to again go back to embryology and phylogeny and try to understand where all those vessels came from. We will start the discussion on embryology on this side, and what we will mention is what we discussed in the last courses. You can refer to those videos, they are available on YouTube. We had discussed how exactly the neural tube is formed. This is now we are talking about the 20-week embryo at the 5 mm stage. At the 5 mm stage, you basically have a set of vesicles, the forebrain vesicle, the midbrain vesicle, the hindbrain vesicle, and the spinal vesicle. We will just have to tilt this a bit. This developing brain vesicle is ultimately going to get connected, and it is going to get its blood supply from the developing heart and from the developing great vessels in the chest. Now, when the heart is developing somewhere at this area, the heart basically gives rise to a series of vessels called as the ventral aorta, which curves back to form the dorsal aorta. The ventral aorta, which is originating from the conotruncal septum where the heart is developing, and this ultimately goes up, and this is connected to the dorsal aorta by the first intersegmental or by the first branchial artery. Then you have the second branchial artery, the third branchial artery, and so on and so forth. From the dorsal aorta, you have the supply to the central nervous system, in which a vessel is going like this. Ultimately, this vessel goes all the way down to fuse with the two longitudinal neural arteries that we discussed yesterday. So what you have to understand is, now this entire system, this lower part is the one that we have discussed yesterday. And the same kind of process will happen even in the upper parts, in the hindbrain, in the midbrain, and in the forebrain vesicle, so that you will ultimately have a long channel which is supplying from top to bottom. How exactly these channels were formed, we have discussed in the previous courses, so we can refer to that. The trigeminal artery will be the connection, the uppermost segmental connection between the supply to the anterior part of the brain, superior part of the brain, and the inferior part of the brain. So the trigeminal artery will come somewhere here. So obviously, when the trigeminal is here, the hypoglossal will be somewhere here, the proatlantal will be somewhere here, and so forth. Now, the optic system develops as what is called as an optic placode. That is an outpouching from this part of the forebrain vesicle. At the forebrain level, as the development is continuing, you will have another vessel which is originating from this loop, which goes up, and ultimately it goes to supply the forebrain vesicle. So by this stage, we are in a position to understand that you have the dorsal aorta, you have the ventral aorta, you have the dorsal aorta, you have the ventral and the dorsal aortic connected by a series of intersegmental arteries, the first arch artery, the second arch artery, and the third arch artery. So you can automatically realize that this is the area which is going to give rise to the aortic arch and the great vessels. Then you have the neural contribution, which is continuing from the dorsal aorta and going up, because dorsal aorta is at the level of the heart. So you have to have one contribution which goes up. So that is the contribution which is going up. And it surrounds the developing neural tube. It develops in such a way that it forms a loop around the developing neural tube and keeps on continuing downwards to anastomose with the longitudinal neural artery. Therefore, this artery, the artery that has originated from the dorsal aorta, is the one which is destined to supply the forebrain. Because now this is the forebrain vesicle. So the entire forebrain vesicle is going to be supplied by this vessel. Now, this vessel is giving a branch, which is dividing into a posteriorly going branch and an anteriorly going branch. So we can automatically understand that the branch which is coming anteriorly from this structure is going to supply the developing optic placode. So this artery will supply the brain, and a continuation of this artery is going to supply the developing optic placode. It is going to supply the central nervous system part of the developing optic placode. So it is not very difficult to understand now that this is going to be the future ICA. This is going to be the future posterior division of the ICA. And this is going to be the the future superior division of the ICA, or anterior division of the ICA, which is represented by the anterior cerebral artery. So now we will leave this diagram and we will just take this part and we will draw a series of pictures where we see what is going to happen exactly in this area. So for that is the carotid siphon. That is the dorsum sellae. That is the clinoid process, anterior clinoid, somewhere there. This vessel is this vessel. So in the first stage, you will have a tiny branch. Now this is the clinoid, so this is the supraclinoid segment. So this is where the optic nerve is going to be, which is central nervous system. So the first supply to this developing part of the central nervous system is going to come from a brain artery, that is the anterior cerebral artery. This optic artery, which comes from the anterior cerebral artery and supplies the developing neural structure, that is basically the optic placode, is going to be called as the primitive ventral ophthalmic artery, because it is located ventrally. So the first branch to supply the optic nerve is a derivative from the anterior cerebral artery, and this derivative is going to be called as the ventral ophthalmic artery. We have also discussed that you have peripheral nervous system available in the retina. That is the retina itself, the first order neurons in the retina. So the peripheral nervous system has to get its supply from the aorta in metameric fashion. But when we go up, you again choose an equivalent of the metameric artery, which is again basically the proximal part of the ICA. Till the ICA divides into its caudal division and rostral division, the siphon part of the ICA, basically embryologically, is still a metameric artery. So at this stage, you will have another branch, a tiny branch, which is originating from the cavernous segment of the ICA, from the siphon, which will again go up, and this will form one more vessel around the developing optic placode. Now, this vessel, the one that has gone on the top, has gone through the optic foramen, but the vessel which is going at the bottom, which is going to supply the peripheral nervous system, will travel through the superior orbital fissure. In the next stage, what's going to happen is the artery that was coming from the ACA and the artery that was coming from the siphon, these two anastomose around the optic nerve, and they form what is called as the primitive optic ring. Now, in the next phase, the vessels that are destined to supply the retina and the choroid, they are annexed by these two vessels, so that this loop gives rise to two long ciliary arteries and to the central retinal artery. So basically, in this situation, in the second stage, what has happened is your ACA is still contributing to the supply of the ophthalmic artery. Your carotid siphon is still contributing to the supply of the optic nerve. You have the supply to the choroid and to the retina, which is originating from this anastomotic ring. This is the second step. In the third step, what's going to happen is this artery remains, the artery that is coming from the lower part of the carotid siphon. This artery remains, which is coming from the anterior cerebral artery. But at the same time, this bend, the origin of the ventral ophthalmic artery, which is coming from the supraclinoid ICA branch, that is the anterior cerebral artery, this comes very, very close to the high flow carotid artery. And this is when it develops another anastomosis with the ICA. Now, this anastomosis on the ICA is in the supraclinoid, supracavernous ICA. So now you can automatically see that you have a system that has developed in which there is one supply coming from the cavernous segment, one supply coming from the supracavernous segment, and one supply coming from the ACA. You'll have the central retinal artery, you have the long ciliary artery, you have the long ciliary artery. Now, automatically, the moment you reach this level, you can start understanding many of the variations of the ophthalmic system that we see in our day-to-day practice. For example, in the next stage, we have this, and we have this. And we have a ring, we have the central retinal artery, we have the long ciliary, we have the long ciliary. So just imagine that if everything goes normally, the segmental anastomosis that is going to disappear is going to be this one and this one. So when you have this situation, you will have the classical disposition of the ophthalmic artery, which is originating from the supraclinoid segment. And this is the most common representation of the ICA that we see. Now imagine that this branch, which was coming from the cavernous sinus, does not involute, but this branch, which was coming from the supraclinoid ICA, involutes. This will be the situation in which your ophthalmic artery is going to originate from the cavernous sinus, intracavernous origin, and this is the so-called dorsal ophthalmic artery. You can have a situation in which both the connections to the ICA, the intracavernous or the infraclinoid and the supraclinoid, both disappear. You will have a situation in which the ICA is coming from the anterior cerebral artery, the so-called ventral ophthalmic artery. You can have a situation in which this remains, but the entire C6 and the C7 segments of the ICA are completely involuted or not developed. You will have an anterior cerebral artery that originates from the cavernous sinus. In its most extreme form, you can have, supposing you have a posterior vertebral agenesis as well, you can have posterior circulation arteries originating from a position in the cavernous sinus. We have examples of all this. We'll show you all this. So what you have to realize is, the moment you start understanding this anatomy, most likely around 50% of the variations of the ophthalmic artery can be worked out based on this matrix. Please remember that as of now, we have only discussed about the supply to the visual system. We have not started discussing the supply to the mesodermal derivatives of the ophthalmic artery. So the next 50% of abnormalities are going to be because of the interplay of the actions between the middle meningeal artery and this primitive ophthalmic artery. So in this disposition, let us draw it like this. We'll erase this one. In this disposition, when you have a supraclinoid arm and infraclinoid and intracavernous arm, these two arms ultimately anastomose. They give rise to the central retinal artery, the long ciliary artery, and the long ciliary artery. This is the ventral ophthalmic artery. This is the dorsal ophthalmic artery. And this entire structure is called as the primitive ophthalmic artery. So as of now, we still do not have any clarity so as to rest of the anterior cranial fossa, rest of the orbit, how it's going to be supplied. Now, this was in a sagittal dimension. We were looking at the whole thing from the side. We will go back to the diagram in which we will look at the orbit from above, and then we will try to see what is the interplay of the meningeal system along with the ophthalmic system. One more important thing you have to understand is supposing both these arms are preserved. When both these arms are preserved, you basically get what is called as a fenestrated A1. Please remember, fenestration is not the correct term. It is not a fenestrated artery. It has not split. It is a lack of fusion or lack of involution. So whenever you see two arms of a fenestration at the origin of the A1, you will realize that basically the optic nerve is going in between these two arms of the fenestration. So you have a fenestration, one arm is above it, one arm is below it. In this fenestration situation, if you have this arm now disappearing, and the ACA is continuing from this branch, this is what is called as the so-called infraoptic course of the A1. So all the abnormalities of the A1 segment, of the ACA origin, and of the ophthalmic artery can be explained based on this matrix. So now, let us go back to the other board, and let us try and explain how the middle meningeal system interferes with this entire system which is developing to form the final predisposition. Again, the midline, the cribriform plate, the crista galli. Now, where we have reached in the normal disposition, what we have seen is you will have a branch that is coming off from the supraclinoid ICA. These branches have disappeared. A memory of this branch can be still intact. You have the primitive ophthalmic artery in which you have a single vessel or two vessels which are giving a loop, which are giving rise to the central retinal artery and to the long ciliary arteries. So now, when we try and draw this here, what we will see is you have the ophthalmic artery. The ophthalmic artery is entering into the orbit. We have again made a dissection in the roof of the orbit. This is dotted line. This is dotted line. Now this ophthalmic artery has come inside. We will draw it as a single line only. It will be easier for us. So this ophthalmic artery, from wherever it's originating, has come into the orbit. And this is giving a tiny loop, which is the remnant of the anastomosis that it was doing with the other branch of the ophthalmic artery. And you have the central retinal artery, and you have the two long ciliary arteries. Okay? We have not been able to supply the supportive structures of the orbit till now. This is when the primitive hyoidostapedial system comes into play. When we had discussed in the previous courses about the persistent stapedial artery or about the hyoid artery, we had remembered, if you remember, there were two branches of the hyoid artery. One branch was going inferiorly, and that was going to become the primitive maxillary artery. And there was one branch which was going superiorly, which was destined to become the supraorbital artery. So the supraorbital artery is the artery which ultimately forms the middle meningeal artery. So what is going to happen is, the middle meningeal artery has been formed from a posteriorly developing vascular system. That vascular system is basically going to give rise to the maxillary artery and is going to give rise to the middle meningeal artery. What happens is, as this artery is reaching the superior orbital fissure, the lateralmost part of the superior orbital fissure, it makes an anastomosis through the superior orbital fissure, transsphenoidal anastomosis, with the developing primitive ophthalmic artery. Now, I will draw the optic nerve over here. That is the optic nerve over here. And ultimately, what also happens is that this artery, which is coming from the middle meningeal system through the lateralmost part of the superior orbital fissure, is going to make a big loop around the optic nerve. When it makes a big loop around the optic nerve, this is a continuous loop. This is a complete loop. So you have a part of it above, and you have a part of it below. You have a segment that is on the medial side. You have a segment that is on the lateral side. The moment it makes this anastomosis with the primitive ophthalmic artery, it also gives off one branch over here, which is going to be the lacrimal branch. And it continues from this loop medially to continue and form the artery which is present on the medial side of the orbital contents. And this ultimately goes into the supraorbital supratrochlear and into the nasal branch. Also, this artery is a meningeal artery. So this artery gives branches via the cribriform plate, and this ultimately supplies the dura of the anterior cranial fossa, of the floor of the anterior cranial fossa, and one prominent branch becomes the artery of the falx cerebri. You can automatically start realizing what is happening here. Also, from this system, from the primitive ophthalmic artery, this anastomosis was at the lateralmost part of the superior orbital fissure. You can have one more recurrent branch which comes through the medialmost part of the superior orbital fissure, and this branch can go and anastomose with the ILT, with the infralateral trunk, which is coming from the cavernous segment of the ICA. So now there will be again a series of readjustments and reorganization in which this will be involuted. The connection between the middle meningeal artery and the ophthalmic system will remain as a very thin artery. You might or you might not see it angiographically. You will have a system in which the entire system of the primitive ophthalmic artery can have an anastomosis which is recurrent, which goes via the superior orbital fissure, and anastomosis with the ICA again. You will have the branches which are continuing from this vascular loop, which go medially, and these will form the blood supply to the floor of the anterior cranial fossa. Now, in the most common predisposition, this anastomosis, that was a part of the anastomotic ring around the optic nerve, the medial limb of it disappears. So the moment the medial limb disappears, now you start getting the final disposition of the entire system, in which the ophthalmic artery is traveling lateral to the optic nerve. This anastomosis, or this crossing over of the artery over the optic nerve, is basically a part of the meningeal system. And if the medial anastomosis has involuted, this will continue via the loop, and this will go and continue as a medial artery, which will give the posterior and the anterior ethmoidal arteries. Imagine that instead of this loop involutes. What will happen? Very simple. You will have an artery which will be on the medial side of the optic nerve. So you need not always have the lateral to medial crossing. You can sometimes have in which the artery has an oblique course and it goes medially. You can have a situation in which, for example, this entire thing is involuted. If this entire thing is involuted, along with this connection, the entire ophthalmic system will come from the middle meningeal artery. Sometimes you can have a situation in which this middle meningeal artery is ultimately going to give rise to the optic nerve related structures and to the ophthalmic artery. And to the lacrimal artery, I'm sorry. Sometimes the middle meningeal artery itself branches out very early. So that what it does is, it branches out and forms the lacrimal artery by itself. This connection is not there. And the rest of the middle meningeal artery, through the supraorbital fissure, gives rise to the ophthalmic system. Now, this becomes important in the present day when we are doing a lot of middle meningeal artery embolizations for chronic subdural hematoma. This is not through a predefined foramen. This is an abnormality, and the canal through which this goes is called as the Hertel's canal. So just a name, but you have to realize that there can be a situation in which the middle meningeal artery, if it is supplying something inside the orbit, you have to check very clearly whether it is supplying only the lacrimal gland, or it is supplying the lacrimal gland and also the visual pathway. Supposing it is not supplying the visual pathway, there is absolutely no risk, and you don't need to go very distal in the frontal branch of the middle meningeal artery. You can embolize from proximal. But supposing it is supplying the visual contents, then obviously your catheter has to go beyond the point where you can have reflux in this area. Sometimes the ophthalmic artery can have a direct origin from the cavernous sinus via this anastomosis. Now, in this case, what you have to understand is this anastomosis, if present, automatically means that the ILT will not be present. Because if this anastomosis would have regressed, this would have been the orbital branch of the ILT. So the moment you have the whole ophthalmic artery originating from the cavernous sinus, it is basically a reliquate of the infralateral trunk. So in that case, if you are trying to find the ILT for embolizing a lesion on the middle cranial fossa, you will not find it, because that is the ophthalmic artery. Sometimes, in very, very extreme situations, you can have the entire ophthalmic system being supplied by the facial artery. So whenever you are working in the external carotid system, you have to be aware that in the external carotid system, the maxillary artery can have an anastomosis with the visual system via the middle meningeal branches and the axillary meningeal branches. The facial artery can have an anastomosis with the pathway with the visual pathway via the nasal anastomosis. The falcine artery, the artery of the falx cerebri, sometimes you need to catheterize that artery as well for embolizing a particular lesion. You should be aware of its communication via the anti-ethmoidal system to the ophthalmic artery. So the orbit, even though it looks like a very tiny area, it is basically an interface of at least 3 different vascular systems. The first vascular system is the situation which gives rise to the central retinal artery. The second vascular system is the situation which gives rise to the long ciliary arteries. And the third vascular system, which is a derivative of a metameric system of the hyoidostapedial system, is going to supply the supportive structures. This automatically tells you that in this entire system, up till here, that means up till the point where the ophthalmic artery crosses over the optic nerve from lateral to medial in its most common form, this is the situation which has been derived from the neural arteries. This is the situation which has been derived from the ventral and the dorsal ophthalmic arteries, which were branches of the anterocerebral artery and the ICA. Which automatically means that any supply to the visual apparatus has to come mandatorily proximal to this bend. You cannot have supply to the visual systems from this segment, because as we have discussed here, that segment is a derivative of the meningeal artery. This entire system, starting from here, going via the Hittel's canal if possible, coming down, entering via the lateralmost part of the supraorbital fissure, the loop around the optic nerve, the medial continuation, and this ultimately continuing into the posterior ethmoidal and the anti-ethmoidal and the artery of the falx cerebri are derivatives of the meningeal system. So the moment you cross this level, the moment you cross this bend, if it is present, if there's a medial predisposition, it's difficult to find it, but if it's lateral, the moment you have your microcatheter across this, and you make sure that you are in a good position with no reflux, there is absolutely no danger to the visual system. You can occlude all these vessels, nothing is going to happen, because the anastomosis at these levels is so strong that it's going to take care by collateral circulation. When you are embolizing lesions of the anterior cranial fossa, you can have 2 different kinds of accesses. You can have an access via the meningeal system, either directly or through its anastomosis via the artery of the falx cerebri, or you can go through the ophthalmic. Most often, we have seen that the meningeal anastomosis is so tortuous that it does not allow us to navigate our microcatheters. So in most of the cases, when you are dealing with complex lesions in the orbit, inside the orbit, or just outside the orbit, or just above the orbit in the anterior cranial fossa, you will have to go through the ophthalmic artery. When you are going through the ophthalmic artery, your ophthalmic artery can be from the cavernous segment, can be from the supraclinoid segment, but you will negotiate these. You will enter into the ophthalmic, you will go as distal as possible, you will cross over the optic nerve, and the moment you are at this position, you are safe. But if you cannot cross over the optic nerve, then there is no chance in hell that you are going to embolize, because you will affect the visual system. So even though the entire anatomy of the orbit looks very simple, it has gone through a succession of multiple phylogenetic compartmentalizations with multiple vessels coming from the primitive anterocerebral artery, coming from the primitive ICA, forming an anastomosis, crossing with each other, some parts involuting, some parts don't involuting. and then you have the final disposition. So if you remember this anatomy, it is enough for you to work. What you have to remember at the end of this is, you have to find the point of the junction of the primitive ophthalmic artery with the definitive ophthalmic artery. This is what it essentially is. The definitive ophthalmic artery is a combination of the primitive as well as the meningeal. So the moment you can find where exactly this point is and where exactly this anastomosis is taking place, you know that henceforth you can be safe. So I think this much of anatomy is enough for the anterior cranial fossa and for the orbit. So if there are any questions, I would love to answer, and then we can go into cases. Any questions?
For the place where it goes lateral is the place of the original loop which was formed in the ventral and the dorsal branches, which you described from the ICA.
This one?
Yeah.
No.
Yeah.
No. Because there was a stage where we had reached like this. So we had reached this stage. And this loop might not be equivalent to that loop. Because at the end of this stage, your artery can look like this. It can look like this also. So the loop that I'm describing is the genesis of the loop is the anastomosis between the primitive ophthalmic artery, which has already been formed, and the middle meningeal branch, which is coming through the superiorbital fissure, and that is kind of crossing over it. So it is at the distalmost point. So you also have to remember that the length of this artery, it can be short. That means the anastomosis can be more proximal, it can be more distal. The length of the ophthalmic artery where exactly the loop is taking place, the length of the artery where the anastomosis is taking place is not constant. So the length of the ophthalmic artery that you will see in the adult, which is the point from where no supply goes to the visual apparatus, is not constant. It is long or it is longer. It is not very short. Because the anastomosis takes place in the distal part just behind the globe. So at least almost up to the globe it will go. But this ring has to be where the optic nerve joins the globe. Because the globe has got mesodermal tissue. The globe is not just nerve cell. So optic nerve, globe, the moment the globe starts forming, you have to supply it with blood. So that is where the meningeal system comes in. Kaushik.
Sir, let us assume that the IC is occluded, sir,
yes.
And we see the reformation of the distal IC through the ophthalmic. Can you just tell us how that we would be seeing? That would give us an idea of whatever you're talking in the reverse phase.
Your ICA will be reformed via ECA collaterals. That's
yes,
what you're saying, right?
Yes, sir. If we were to run an angiogram from the ECA,
okay,
from the middle meningeal, how it would reform the ICA, that would give us an idea of how what you have explained in the reverse.
Okay. We'll draw another diagram for that. Midline, cribriform, open the roof. So in reverse now, what are the anastomotic channels that you have? You have the middle meningeal artery, which is coming like this. This middle meningeal artery is going to go all the way to the free edge of the tentorium. It's going to go behind. So this middle meningeal artery has got the capability to give up to 2 collaterals. It can give 1 collateral via the superiorbital fissure. If the Hertel's canal is present, and if your lacrimal artery is coming separately, that can be the 2nd collateral. So from the middle meningeal artery, you have these two vessels. From the nasal branch of the facial artery, you're going to have one more branch, which is going to come from here. It's coming from below. And then ultimately, it's going to come and anastomose with this part of the ophthalmic artery, which was running on the medial side. So now, when you are injecting the external carotid artery, you will have one pathway like this, and you will have one pathway like this, and these will ultimately form the ophthalmic artery. Now, this ophthalmic artery will reform the carotid siphon either at the supraclinoid level or at the cavernous sinus level. So this is basically the pathway of the reformation of the I'll show you a case. We have a case which I'll show you in which this connection was supplying the ICA territory, and because of this territory, obviously this is not used to that kind of a flow. So we had an aneurysm here, and the patient presented to us with both an ischemic stroke and a subarachnoid hemorrhage. I'll show you that case. Fine. Any other questions? Which one? This one. See, this is the ophthalmic artery medial branch, which was there, which is not occluded. This ultimately goes in anastomosis with the supraorbital, the supratrochlear, and the nasal branch of the facial.
Yes, sir, but now in this situation, where did it reform from? Ophthalmic was absent, right? It came from...
No, ophthalmic was not absent. Ophthalmic was not getting filled from below.
Yes. So
but the artery is patent. Okay. So if it's not getting filled from below, and if you inject it from the other side,
okay, from the other side,
it will come from the other side.
From the other side. That's right.
It'll be from ECA. That's why whenever you do a case, for example, you do a flow diverter across the ophthalmic artery origin, and then you don't see the ophthalmic. So immediately what you have to do is you have to go to the ECA and inject and see if these are forming. Because the flow is competitive. If you put a flow diverter somewhere here, it's going to reduce the amount of flow which is going to go into the side branch. But if those connections are very strong, it will immediately take over the supply, and then your ICA injection will not show you the ophthalmic, but the ECA injection will show you a big ophthalmic.
So the connection from the MMA to the ophthalmic is mandated through the Hertz canal and lacrimal?
No, it is usually through this. It is usually through this, through the lateralmost part of the supraorbital fissure. And then, once it enters from here, it can branch out into the lacrimal artery separately. This is an exception. In fact, I'll show you a case of a middle meningeal artery embolization where this was the case, in which you were seeing some orbital supply, but it was only the lacrimal, because the ophthalmic was coming from somewhere else.
See this so-called dangerous anastomosis between middle meningeal and ophthalmic. If you see good ophthalmic in the ICA, it is said that written in the books that you need not to worry too much about the middle meningeal artery. Like so,
absolutely not. If you see a very good ophthalmic, which is coming from the ICA, it just means that the dominant flow is from the ICA. This is not a dangerous anastomosis. This is an anastomosis which is always present. It is dangerous because we don't recognize it. This connection between the middle meningeal and the ophthalmic is always present. It might be very small. It might be so small that you don't see it. But you cannot assume. You have to go into the middle meningeal super selectively and inject with pressure and make sure that that is not the case. Because otherwise, no assumptions. In fact, my late teacher used to say that there is no dangerous anastomosis. It is the clinician who's dangerous, because you don't know what is happening. Any more questions? No more questions? Okay, so I think we can see some examples of the ophthalmic artery that we have been discussing, and then from there, we will then go to the therapeutic sessions.